So the next topic for me is going to be fetal therapy. Now, fetal therapy is a very hyper-specific topic. Hyper-specific का ये मतलब है कि you will only encounter it in your careers if you happen to be a fetal medicine expert. Otherwise, you are never going to encounter it. So the next topic is going to be fetal therapy. Now, fetal therapy is basically treating the fetus when it is inside the uterus, when it is inside the womb. So just like an adult, similarly, the fetus is a human, and any human can be treated in two forms. It can either be a medical management or it can be a surgical management. So when we talk about medical and surgical, similarly in medical, we can have, just like in an adult, we have multiple routes of operating. It can be an open surgery, as if I have something like a lipoma on my hand, a large lipoma, which is making me very uncomfortable. I just resected it. So it was an open surgery. बड़ा surgery करके मैंने निकाल दिया. या फिर I'm a female who has a fibroid, a large fibroid. So I opened up my body, open myomectomy was done, and I restored the uterus. So open surgeries, they can be done where we are using an actual scalpel and blade and everything. The next can be endoscopy. Endoscopy, just like in adults, we have laparoscopy. In fetus, we shall have fetoscopy, wherein we are inserting a camera inside the, sorry, when we are inserting the camera inside the fetus and we are operating. The third one is going to be in a surgery. The third one is going to be percutaneous. What is percutaneous? Just like you have heard of percutaneous angioplasty, them placing a stent, they go through your artery, they go inside. Basically, they're just going through your skin, through your entire body, and then coming to the heart, and they're doing some procedure. So percutaneous is through the skin, through cutaneous is skin. So these are the three modalities of surgical management in fetus. Where do we use them? This was a basic classification. So first talking about medical management. So whenever I'm talking about medical management, I have to understand a few things. I have two ways of delivering. I have two ways of delivering the medicine. I can either give it to the mother and then the mother will pass it to the fetus, or I can directly give it to the fetus by injecting it into the amniotic fluid. But of course, if I'm going to inject something into the fetus or into the amniotic fluid, it's an invasive procedure that can lead to risks of PPROM, preterm premature rupture of membranes. So I wanted to do something, but I ended up giving her preterm labor. I do not want that. So what do I do instead of that? I give it to the mother in sufficient quantities that it will cross the placenta and achieve adequate concentration in the baby. So what we have to ensure whenever we are giving it to the mother is, first of all, it achieves adequate fetal concentration, very important. And secondly, I have to also ensure that the placenta doesn't metabolize it. And it doesn't happen, metabolism can go in two ways. One is that the drug can be completely destroyed, or the second thing is it converts it into some metabolite that is toxic to the fetus. I do not want that either. Hence, I have to ensure that both these concentrations or both these indications or both these prerequisites are fulfilled. So, what are the various conditions that I'm going to be treating? The first one happens to be arrhythmias, fetal arrhythmias. Just like in adults, we have bradycardia and we have tachycardia in fetus. So how do I diagnose it? First of all, now I don't know, for all those who have seen an ultrasound being done, for them, in an ultrasound, there is a technique called as the M mode. M mode mein you see movement of the part that you are trying to see. So usme, if this is your four-chamber heart, ये अगर फोर चेम्बर हार्ट है, so there will be several waves that will be seen. तो एक वेव यहाँ से जाता है, एक वेव यहाँ से जाता है, एक वेव यहाँ से ऐसे. So this wave is going to represent my atrial contraction, whereas these three waves are going to represent my ventricular contraction. These two are going to represent my atrial contractions, and these three are going to represent my ventricular contraction or ventricular movement. So my graph is going to look like ventricle atrium के level पे ऐसा है, ventricle पे level पे ऐसा है. So ideally atria में जितना है उतना ही ventricle में होना चाहिए, for what we call as the atrioventricular concordance. Basically, the same number of contractions that the atria is having are being transmitted to the ventricle, and उत्सर भी उतना ही आ रहा है. So if there are 160 atrial contractions, there have to be 160 ventricular contractions. But it can be distorted. It can be distorted as to the atria is having one contraction, in comparison the ventricle is having two contractions, or the other way around. The atria is having two contractions or the ventricle is having only one. So basically there is some blockade, or probably there is something in the ventricle that is causing it to have its own beats. So all these things are going to lead to arrhythmias. Now, when I talk about arrhythmias, first I'll talk about tachyarrhythmia. So when I talk about this tachyarrhythmia, I can have two possibilities. One is supraventricular tachycardia, or I can have atrial flutter. So supraventricular tachycardia, my pulse is going to be between, the fetal pulse is going to be between 200 to 250, whereas in atrial flutter, it is going to be between 300 to 500. So isme, the rate has increased significantly. So now that the rate has increased significantly, I have to also check whether it is sustained. What do I mean by sustained? Is it like it is just being there for 1 second and it is not there for the next 10 seconds, or it is sustained? Sustained matlab for more than 50% of the time. So basically 1 minute में more than 30 seconds के लिए I should be able to see that arrhythmia. So if it is more than 50%, then we call it sustained. What can be the various causes? The causes for that heart to beat rapidly can be something like fetal anemia because of parvovirus or Rh isoimmunization, or it can be an infection, or it can be because of maternal fever, maternal infection. For some reason, maternal pulse is also high, and hence you have fetal pulse high, which is what you often encounter, or hyperthyroidism. So these are the various reasons why a fetus can have hyper rather increased pulsations or tachycardia. So what are the treatments? The treatments are very similar to what we give in adults. We want to control the rate. So I will give maternal digoxin or flecainide, or a drug very famously called as Sotalol, a beta blocker. So all these, Flecainide is a calcium channel blocker, Sotalol is a beta blocker, Digoxin is a proper Digoxin is a digitalis-like drug. All these are going to control the rhythm and the rate. We have to give it to the mother. Of course, the side effect is going to be maternal bradycardia. Mother ka bhi kam hoga because you are giving it in high concentration for it to cross the placenta. But this is going to be the drug of choice for any type of tachyarrhythmia in the fetus. So when I'm talking now about the bradyarrhythmia, it can either be because the heart is structurally abnormal, or it can happen in a structurally normal heart. So in a structurally normal heart, it is going to be because of something like maybe the mother has something in her like SLE. In SLE, if there is neonatal lupus and there are antibodies, which antibodies? SSA and SSB, which we earlier called as a Rho and La antibodies, if they are being crossing mother से fetus में आ रहे हैं and they are causing congenital heart block, very likely, or if there is structural abnormality called as isomerism, something that is beyond the scope of this discussion. So isomerism is basically you have either two left ventricles and left atrium, or you have two right atriums and two right ventricles. So if there is a case wherein there is complete absence of the right side of the heart and there is only left atrium and left ventricle and they are multiplied. So basically there are two left atrium, two left ventricles. Then you do not have your SA node because your SA node was usually present in your right atrium. In that scenario, if there is nothing to initiate cardiac activity, your cardiac activity is going to go down and there is going to be bradyarrhythmia. So what do I do? So there was a PRIDE study, and that PRIDE study full form was PR interval and dexamethasone, oral dexamethasone therapy. So they decided we can do nothing about isomerism. It is a structurally abnormal heart. You will have to do an MTP. But for this reason, SSA and SSB, wherein mother's antibodies are going to the fetus, what we can do in that scenario is we can give the mother dexamethasone, and dexamethasone can be given 4 milligrams per day. They said that this 4 milligram per day is going to suppress the maternal SLE, and that maternal SLE, once suppressed, will help to prevent the transmission or the vertical transmission of the antibodies, the SLE antibodies, the SSA and SSB antibody from the mother to the fetus. So basically, it was corticosteroid immunosuppressive therapy that was given to the mother. The success rate hasn't been really as great though, and hence these babies often end up having hydrops. So this has to be initiated before hydrops. And if not initiated, it will eventually progress to hydrops. And once hydrops develop, then there is nothing that you can do. The next option that you have for SLE is going to be HCQ, that is hydroxychloroquine. And lastly, if there is nothing that is working, then you have to give the mother a high dose beta mimetic. Beta mimetic is basically something that is going to increase. Earlier we had beta blocker for tachyarrhythmia. Here we are giving beta mimetic, that is a beta agonist. So beta agonist is going to increase the maternal pulse as well as the fetal pulse. The problem is going to be that the mother is going to start experiencing palpitations, which is not a comfortable thing. She can also have her own heart ailments, hypertension, and hence this is a very dangerous therapy to give. But agar dena hi raha, so the drug that we give is the same drug that we give for tocolysis, and that is terbutaline. So this is about tachy and bradyarrhythmia.